Let's get started now. I'm Raj Singh. Welcome everyone to Essex family of families, Shakes. So Shakes is sharing knowledge, experience, and skills. We are less than a year old, small entity. Uh, we have actually given few programs in the past, like we have Working Mothers Ditch the Guilt, diabetes, diets and lifestyle, and 11 plus in a nutshell. So we have given three programs. We have two programs already in the YouTube. This session is going to be given by Dr.K.T.Ramesh. Just a few housekeeping things before I ask Raj to introduce Ramesh. So the session is being recorded and it will be shared in it will be shared in the social media, and also we'll be actually taking questions at the end of the session. So we have currently, you all will be muted. So any questions, anything, please share in the chat. We'll actually pick up questions. Raj, could I invite you to introduce Dr. Ramesh? Thank you.
Sure, Raj. Thank you so much. Okay. Hello, everyone. Good evening. And on behalf of efof, Essex family of families, I would like to welcome you all once again for this wonderful, unique evening. Unique? Yes. Today, not only the topic, the palliative care is unique, even the presenter is very unique because of its qualities. In life, very often we come across a person who always successful in some of his role or one of his roles. It may be excellence at work or exceptional focus on family, friends, relationship, or extraordinary socializable activity. But it is very rare you can see a personality who can do wonder in all these roles and managing all these roles so wonder, and we can say that is not a one role wonder, is an all role wonder, is an all rounder. Definitely this person is a kind of all rounder, as he is running efof group in association with Raj Singh for showcasing the talents of Essex, and he's running the Muttamil Academy to promote Tamil culture, language, and values. And he is running Muttamil Fans, a YouTube channel for showcasing the talent of individual and fellow humanity. And beyond all, he's running the Way to Paces, which is a MRCP training course to help doctors to come and work in UK. And beyond all this, you're also helping the friends for running the badminton sessions to keep friends fit and have fun together. And the list is not ending here. I'm sure he has a lot more in his list and even a lot more in his plan. But this is just cherry on top of cake. Because assume all this is just in addition to what he's doing in his work. He's doing excellence at work, and he's an extraordinary father and husband, have excellent focus in family. And again, he do how much socializing we all know with efof and doing a lot of quiz and entertaining everyone now and then. And this reminds me always life not necessarily to be this or that. Always we go around either this or that, either work or fun, either health or wealth, either friends or family. Life also can be this and that. And he is a living role model for a time for everything and everything in its time. So you can manage time and everything you can have it in your plate. So I like this, many other qualities of this personality. This is something which I always adore. Netricum thirapinum kutram kutrame. It means even if it's a god, wrong is wrong for him. It doesn't matter who does it, who's doing it. The man always fight, whether he's affecting or not, he's always fight for on behalf of everyone. A true warrior who always fight against the bad thing, who fight for the righteousness, never worried about the winning the battle or not. A man of righteousness. He might lose many things, but never lose this quality of fighting against and fighting for the righteousness. And this person is not only doing with passion everything and also have compassion towards humanity. That's why he chose to serve this critical, sensitive, critical care, palliative care, and serving it for last more than 17 years as a doctor, as a professor, as a mentor, and lot more. An excellent doctor, a sensible, supportive colleague, highly skilled and compassionate, approachable and helpful always, excellent colleague and clinician, a good role model doctor. These are not just my verdict, these are coming from the heart of his own colleagues. Imagine who has been worked with him for a long time and how hard to get such kind of wonderful accolade from our own companion. And definitely, he is a wonderful asset to the medical fraternity. And now it is time for listening from this great personality. And let's welcome the man of all round wonder, a man of righteousness, a man of planning, a man of punctuality, a man with a passion and compassion as a heart and soul of his life. Let's welcome your beloved and my beloved Dr. K.T. Ramesh. And before over to Doctor, just a reminder for housekeeping. As Raj mentioned, we will be keeping all participants as mute. And if you have any queries, please send it in chat. And after the presentation, the doctor will answer all the questions, and then you'll have face-to-face interactions as well. Thanks to all once again for joining us. Over to you, Doctor. Thank you.
Thank you, Rajchandra, and good evening, everyone. Rajchandra told so many things. It's a big list he told, but everything is a one list only. So you can combine everything as a one. It's a normal personality with support from friends and families. That's it. Without that, it's nothing is possible. And I don't know, because now it's the time to start my presentation. After Rajchandra, I'm just thinking, do I need to present anything or not? Let the Rajchandra itself can do the presentation. That's we'll come to that in a minute. So I'm going to share my screen and then we'll start the presentation. So that's today. It's efof.shakes on palliative care. So today, palliative care is just like an ocean. It's very difficult to tell about or dip the ocean in 1 hour, and we all know that. But I got a little bit of structure towards it. Whether we stick to the structure or not, that's another question. Let's see how things go. So first of all, palliative care is a form of a treatment. To know about the treatment, we need to know about the disease or the illness or condition, whatever you say. That's a starting point. And I would be elaborating what are the kinds of diseases or illnesses and how that affects us with different severities. The next thing is about treatment options. So when people get illness or the conditions, what are the options generally? We'll have a look at this. Prognosis. Now I know some people are thinking, okay, after seeing this, okay, do I need to stay or do I need to go? So that's where it is the palliative care. It slowly step into like a depth prognosis. And then emotions. Say again, any field like a healthy or unhealthy, or when I say unhealthy, it's nothing related to lifestyle or anything. When I say unhealthy, it's just like a people with diseases or illness, unfortunately. When we deal with all those things, it's not only physical. Sometimes we focus only on physical things. Let's say, for example, pain or any sickness or anything, but it's always a huge role of emotions there. But particularly with the palliative care, definitely there are emotions. I'm going to just touch base on those things and on behalf of all of us. The next thing in terms of, let's say we are talking about palliative care and what to do, the care needs and where to go and what are the options. So that's a little bit of briefing over there. And the last is a take-home message. See, when I do all these things, how I come to this topic, it's not given in any books or any journals or anything. These are all based upon my experience and like my experience with my friends and families. And also I get calls, let's say friendly calls, all of them from anywhere around the globe about palliative care, decision making. So these are all the things people are needing to know about. And then I will tell whatever I know in my like a little 17 years of experience. So from those questions and then suggestions, so I put it through there. Hopefully it will be helpful. Let's see how things go. First of all, when we talk about illnesses, we need to classify the illness as two different types. One, acute, and the second thing is chronic. When we talk about acute, it comes on suddenly and then lasts for a very short time. At the most, I would say a few days to a few weeks. Then it will settle, it will go away. Reversible factor is absolutely there. For example, let's say the common cold, yes, we'll be under the weather, and then just when things get better, we all become all right. Then let's say a bout of loose stools just for a day or two, and like a temperature, if it is related to viral fever, then that is also there. So these are the, let's say, headache. So there's a big list there. Anything we get suddenly, lasts for a short time, gone completely, few days, after weeks, with or without treatment. That's acute problems. And now coming on to chronic problems. So these are the conditions which is highly related to palliative care. That means they develop slowly and may worsen over extended period of time. And the overall period of stay with us, the chronic illness, may last from months to years and years, unfortunately. So that is the first difference we need to know about what sort of illness we have got. When I say we, let's say it might be us or our friends or families. The next thing is about, as I said, palliative care. It's related to chronic illnesses mainly. I'll just go through the phases of chronic illness in general, and then I will cut short the phase into like what we are going to see and explain each and everything. So first of all, let's say the initial, or forget about the trajectory phase. Let's leave that. So let's say initial phase. So chronic illness is occurring, but it's not causing any symptoms or signs. Symptoms are the problems we have. Let's say shortness of breath, pain, vomiting, anything we call symptoms. Signs or what the doctors or medical profession or any healthcare professional will find from us. When I say signs, for example, increase temperature and then check the blood pressure. So those are the signs. Symptoms are the problems. Next one is the trajectory onset, where the problem is there or the illness is there, but it started giving signs and symptoms so that we know, oh, something is wrong here. With these two, or like a preliminary early stage, we'll jump on to the two other things. One is the crisis. The second thing is acute one. See, when we talk about crisis, we all know what the crisis is. But unfortunately, some of the chronic illnesses can present as an extreme level of crisis, leading into life-threatening situation. Can do that way. And the next thing is about an acute phase. When we call an acute phase, it may or may not follow a crisis phase. But in those situations, the symptoms or the problems can be controlled by a prescribed regimen. And when you talk about regimen, either with the medications or lifestyle modifications, anything. So the chronic illness is there. Either it's there and not causing any problems in terms of symptoms or signs. It's there and started giving symptoms and signs. The crisis is where when it is extremely urgent and emergency things, sometimes leading on to, unfortunately, life-threatening situation. An acute phase is the one, yes, there's something there, but it's getting controlled with the available regime or the treatment with any forms of treatment. The next 4 stages, let's say the stable phase, and this phase starts once the symptoms are controlled. So there is some problem there. Let's say somebody has problem with the pain or breathing difficulty or any problems, and then with the medications or added on lifestyle modifications, you control the symptoms and there are no problems. But the chronic illness, unfortunately, is still there. That is the key message I want to discuss with you all. Yes, there are some acute phases and we have problems, but with the control, is still the chronic problems are there. The next phase is unstable. Unstable is whenever anything like a shaking the boat, what we say generally is everything is stable. Suddenly something happened and symptoms become uncontrolled by the what we said was adopted regimen previously. We had something in control and suddenly it goes down. That's unstable phase. The next phase is a downward phase. See, when people are unstable, we'll do the same thing again. Okay, we know what the treatment is. Let's say, for example, chest infection, antibiotic. Yes, give antibiotic. And then it settles. And chest infection, I say it comes under acute illness. But when people have a chronic illness, already they are having certain problems. But on top of it, chest infection is becoming a second blow to our system or let's say body. So in that case, it may not be getting controlled and it adds to the point. So that's where we give antibiotic either orally or let's say through injections, through the veins, and then make things into consideration and steady level. So in those situations, when people are unstable, they can either with the treatment can go to stable, or unfortunately sometimes they don't respond to the treatment and they go on to downward phase, which is called progressive deterioration. And when people are entering into progressive deterioration, from then onwards, unfortunately, they deteriorate further more in terms of the period of weeks, and it reduces slowly to days and hours, unfortunately, in the dying phase. So these are all the 8 stages of chronic illness, can present in any way, and people can be in any particular phase of illness at one point of time. But because it's the 8 things, I try to summarize or conglomerate into a simple 5 stages of, let's say, for example, initial stage, and then stable, unstable, deterioration, late stage, or the final stage. So in this one, as I mentioned before, unstable is the key we need to look in terms of. See, let's say people have chronic disease or the chronic illness, and they can become unstable with any problems like a simple chest infection. In that case, the primary thing is we need to observe with the treatment whether they are going to be stable or whether they're going to have a deteriorating stage. If they go to stable, then it's exactly remain there. We don't know how long. Then we can say all the treatment regime can be continued. But unfortunately, when people go from unstable to deteriorating, then they will pass on there to the late stage or the final stage. So how do we determine whether people are in the initial stage or stable, unstable, deteriorating, or final or the late stages? It mainly depends upon the duration of the illness and also the complications. Let's say, for example, diabetes. See, when I say diabetes, it's diabetes mellitus, because there is another diabetes that commonly we call high sugar, high glucose. That's a diabetes, which I'm talking about. So duration of illness, let's say we got diagnosed with the diabetes today. And then after 2 years, after 5 years, after 10 years, again, with the duration of illness, it can cause problems to our body. And then it started causing a complications, what we say. Let's say, unfortunately, it can affect our eyes, like vision. It can affect the kidneys. It can affect the nerves. It can affect the heart functions invariably. So those are what's called complications. So this is where we need to say, see, let's say, for example, somebody got diagnosed diabetes just yesterday, and then no other problems. They just went for a check, and then it's high. See, until we see what other complications have happened, they will be coming under either initial stage or a stable stage, because we need to give medication to control the sugar, or even not even medication. Let's say people say diet control is enough. So they come under stable stage. But unstable is suddenly the blood glucose is sky high. We try to control everything, is the same diet, the same exercise, but still not under control, means they become unstable. And if the same person, let's say having diabetes for 10 years and had problems already with the various systems, as I mentioned before, with the problem with the vision, kidneys, heart, and nerves, then they go on to deteriorating phase. So this is just an example with the diabetes. This we so far we talked about only the chronic disease or the chronic illness. We have not mentioned about people, and that's the key in terms of whatever it is. The main thing is people's ability to fight against the illness determines which phase they are in and how vulnerable people are to the disease. This is, I'm saying, because let's say the same diabetes, same blood sugar high level for one person may not affect the other person. Same level, same age, let's say everything else is same, but still one person might be stable, the other person might be unstable and deteriorating. And that's the key message we all need to understand, because we often tend to compare. Okay, this is what the stage of illness is, and then what is your blood sugar? What is your blood pressure? So how well are you? But again, it's completely different, and people's ability to fight the illness determines where are we in the phase. The one is the chronic illness and the duration of illness and the complications. 2, our ability to fight against the illness. That's invariable ability in there. So we cannot change. It's sometimes related to genetic and sometimes related to nothing. We don't know why, but we are like that. We talked about just one problem with the chronic illness. Unfortunately, sometimes we have many problems or one or more problems. So in those cases, what do we need to think in terms of how well presentation would be. See, let's say, for example, I've listed all the problems. Don't get scared about all the problems. So just for an example, let's say a person has a diabetes, heart problem, kidney problem, stroke, and the nerve problem. I've numbered 1, 2, 3, 4, 5. And then now say diabetes, whether it's stable or unstable or deteriorating, and the heart problem, again, stable, unstable, deteriorating. Let's say, for example, stable. All the 5 problems are there and people are stable. Okay, everything under control with medications. There's no problem at all. That's fantastic. We are going on to that stage. But when we say, for example, at least one of the problem, when they become unstable and then deteriorating, it will hit the other problems as well. Unfortunately, these medical problems are like a thick friends. If one gets affected, will get affected. I'm not telling friends will get affected with that. Don't take to that level. But just like a friends, when I say they're all group of people and they're all together, like the diseases or illnesses. So if one gets affected, the other will get affected invariably, unfortunately. And in that case, one, let's say the kidney problem is unstable, and then you try to reverse it with many things. And then suddenly, if let's say it goes towards a deteriorating, and that will invariably affect the other problems. The reason I'm telling this is the treatment. I'm not coming to the treatment at all, and I've not mentioned, except for the first time, I've not mentioned palliative care at all so far. So this is generally understanding the duration of illness and complications and illness per se. So one illness, longer duration, lots of complications, is going to affect in a one way. Means if the same person has a 2, 3, 4, 5 illness, then it will be, it won't be like an exponential way, but it will definitely, there will be an impact in a cumulative way. That's what we need to understand. If people have so many problems, and if all the problems are unstable, one affects the other, and unfortunately, after a long duration, they go on to deteriorating. And also, I'd like to mention the people ability to fight against illness plays a major role, and mobility is an important factor or is an important indicator. When I say mobility, that's our strength. See, somebody, let's say a person is mobile like 3 months ago without any help, and suddenly he had all the chronic problems getting worse, unstable, and then he tried to do with medications and treatment regimen, it's not working, unfortunately pushed into deteriorating stage. Then in that case, the mobility is a marker of the deterioration. Even without anything else, mobility is a great marker. It will affect the mobility when the diseases get worse. See, when I say even without anything else, I would like to give an example here. Let's say, for example, an elderly person, I wouldn't tell the age because elderly differs from country to country in terms of age. Let's say elderly, after an old age person, and walking, talking, everything is fine. Suddenly had an accident, fall, and then broken hip. Then we can't do anything with the fracture because of the frailty and the age, and then the mobility goes down slowly. Let's say in that case, we need to think about, and people think, okay, the mobility has gone down, and then that is okay, what to do? Other things that everything is fine. But the tricky thing is, when the mobility has gone down, we need to think in terms of why the mobility has gone down. Because when people fall, it's not usual to have broken bone. That itself tells us the person is frail, unfortunately, and that leads to weak, like a whole system. And that's why one affecting the other. And when we talk about treatment options, see, generally, I put surgery here because so far I've not mentioned the dreaded cancer here, but I don't want to mention and scare people here. Just put that in the mix. So any treatment, let's say problem, and there is a treatment. If there is a surgery, we all know there's a definitive treatment. Okay, problem, remove the problem, that's a surgery. That's one of the options. Medications, yes, there are certain medications to control the problems, but there are special medications towards that. So if you go in terms of, let's say, for example, cancer, there are cancer medications there. Different types of cancer can have new medications there. So that's also a possibility. And then a non-medical treatment. See, when I say non-medical, it's not about medicines. It's about like a support, physiotherapy, and then like a complementary therapy. All those are the medical treatments available. And I just mentioned about non-allopathy treatment. I don't know anything about non-allopathy. If you ask me in terms of what medications and what is the drug and what is the effect, I don't know anything about. The reason I mentioned about it, sometimes people ask me whether I can go to non-allopathic treatment at this point of time. Again, the tricky thing is when people, it depends what phase or what stage of illness people are and how that phase has affected that person. If unfortunately people have gone to deteriorating stage, it's very, very difficult to get them back to unstable. And when we say deteriorating, after doing everything only we will say is deteriorating. At the first shot, we won't say. We consider everyone as an unstable and then try to do different things. But when people are not responding, one, due to the illness getting worse, two, due to the people's own capacity to respond to the treatment, then that's where we would be saying deteriorating, unfortunately. So in those cases, in my experience, not my own experience, but people telling me, unfortunately, none of the people had a good experience or they had come back to the stable phase with non-allopathic treatment. So I'm not like a black and white saying don't go there. In my experience with the patients and the families and friends, I've not had any great benefit. And when people are deteriorating, I would say we need to be working in a different way. And that's what the next thing, not doing anything for the illness. See, that unfortunately, that's an option. Anything, not doing anything is an option. But here, that is also an option. When people are deteriorating due to the chronic illness, when they are moving on to the final stage. And that's where I'm all about like a palliative, an end of life, and preferences, and then comfort is the key. Now I can tell the palliative is when there is no cure and when there is a life-limiting problem and when there is a clear-cut deterioration without any problems, that is where we say palliative. That means we won't be able to do anything for the illness, but we can only make people comfortable with the available medications. And end of life, I put it here. I know it's a very strong word, but again, that's where the last, let's say, the few weeks and few days and few hours of life, we combine everything as end of life. So that's where when people say deteriorated and where due to their limiting illness and things, we call end of life. Preferences. So when people are moving from, let's say, curable to incurable slowly and then deteriorating end of life, the preferences change. The medical treatment, which were helping in the first phase, may not be helping now. And that's why people preference. See, let's say, for example, a person who is very old and lives in a village and in his own house, and he's in a deteriorating stage, and we have tried all the medications, unfortunately, nothing helping and becoming more weaker and weaker. That particular person preference will be like, okay, don't go anywhere. I don't want to go to hospital. So that will be a big shock for the family and friends, definitely. So why? There are medications there. We need to go to the hospital and see how things go. But that's where the preferences come into play. When the medicine, see, medical preferences, I've listed all. But there is also a stage, unfortunately, not doing anything for the illness is there. Because there is no medication can control because the illness is getting worse. But preferences, that's also a major role. And we need to respect that preference and see what we can do, help that person in that particular situation. And this is, again, a crystal ball question always, prognosis. Generally, everyone asks me, how long have I got? Or let's say in terms of families and friends, they will ask. So there is a simple, when I say simple, indicator-wise, it is simple. So I'll go to the previous one. So first of all, a reversibility of the condition, and then what that condition had caused a significant change in a particular person. And in that, the mobility is equally important. Let's say we are dealing with an irreversible problem, and that irreversible problem had made a significant change. When I say significant, it's not about, let's say, 3 days, like a bit tired and sleepy in bed, not able to, it's not like that. See, let's say somebody were walking and then now is completely bedbound. Let's say somebody is very alert and now they are sleeping and they are not able to talk. They're very weak. They can't do the dressing by itself. They can't eat. They need help. They can't mobilize. They need help. So those kind of significant change, and when it's irreversible, then that's where we need to talk in terms of palliative care and make people comfortable and not doing any aggressive treatment. Not because we don't want to do, but unfortunately the option is not available. If somebody is in a situation, let's say irreversible and significant change has happened, then the rate of decline goes with the change. I'll rephrase the word. When somebody deteriorates with an irreversible condition leading to a significant change, if that is happening on a weekly basis, unfortunately, we are looking in terms of weeks. I straight away jumped from like years, months to weeks, because to show that the palliative end of life route is there. And then when the same deterioration happens on a daily basis, we are looking in terms of days. And unfortunately, sometimes we may need to see people in the last hours of life. So the similar thing, irreversible condition, significant change happening within hours, and we are looking in terms of hours. This is what we say. And sometimes people ask us in terms of numbers, how many weeks, how many months. I don't think we can say. And the question will come, how confident you are in terms of prognosis, telling and then prognosticate some people. See, when people deteriorate, as I said, in terms of years, months, weeks, days. So when it comes to weeks and days, the prognostication would be more accurate and precise rather than years. So when, let's say, one doctor says 2 years, other doctor says 3 years, it's very difficult. But when, say, one doctor says 2 weeks, and it's not like a 7-8 weeks for the other doctor, if the assessment is particularly correct and followed all the steps in terms of phase of illness and significant change, and also how well it's affecting that person. And as I mentioned, mobility is a very important indicator of the prognosis. Emotional changes, we've talked about the illness, and then as I mentioned, palliative care is not without emotions. So we do come across all those emotions will be there. First of all is denial. When there is a deterioration, when doctors tell people, let's say, we don't have any treatment options for this chronic illness, first thing is denial. No, that's not me. It's not me. It's not going. I'm not going there. So I can reverse. And then people try to ask second opinion, third opinion. I don't have any problem in that, and that's perfectly normal because denial is a strong coping mechanism. But the thing is, we need to have a time frame because denial can't be there under deterioration, and near the final stage, denial is a little bit tricky thing in terms of working together with the family as well as friends and healthcare professionals. So that's the denial, first of all. Second thing is anger. Again, we have been pushed into deteriorating state, and we don't want that. Nobody wants to be on the deteriorating stage. Everyone wants to be like a stable or not even medical problems. But unfortunately, we do have the anger will be there. The next stage is the bargaining. Bargaining is, okay, now I'm going on to this. So if I would have done this, how can I do this? Can I do this X, Y, Z to make it better? So those kind of things, we are expecting an answer in terms of changing the deteriorating phase to a stable one again. And the last stage is the depression. When I say loss, I'll come to the acceptance, the loss of the 4 main things of depression. So depression is, yes, we come to know we are in the deteriorating state and then we can't do anything more. And then obviously we tend to go low and then we won't be doing everything there. That's the depression stage. And the final, very important stage is acceptance. See, acceptance is like, whatever I'm telling, it's not about the theory. It's a practical life and it's happening. And when people are there, it's like we need to, at one point of stage, people will come to acceptance. There'll be a big difference between, like, when people sometimes say, like, giving up. No, accepting means it's giving up. No, I want to fight. And the acceptance is there. So what's the difference between? Giving up means there are options there, but still we opt for, no, I'm not going there. And I told you about like a gentleman or a lady or friend or family in a village, and they want to stay there in their home. They don't want to go anywhere, even though something are reversible. I come across so many times. I say to the patient, okay, you have got so many things, go to hospital. And people say, no, I don't want to go. See, that itself is its acceptance or the choice. And that is not a giving up, that's the choice. But acceptance is there are no options available. And then we are going with the illness. And then changing our focus from cure to care and comfort. That's the acceptance. But it won't be in the same order. Let's say we say, I accepted everything tonight and then come to terms, okay, everything fine, comfort, decided. Tomorrow morning, I get up and then say, oh, no, nothing is there. I'm not going there. So that is possible. That's where I put like a juggling ball. These 5 emotions can be any time. One day, even the same day, we can change. Morning denial, afternoon anger, and then evening depression, night acceptance. And next day morning, again, bargaining. So it's a very hard time and a difficult situation when we were pushed into deteriorating situation. But that's why I put the juggling balls there. But we won't be happy like that lady in the juggling balls. It's extremely tricky. And the last slide in terms of care needs. Let's say one of our family or friends had unfortunately chronic illness and moved on from stable, unstable, deteriorating, and then the final stage. So how to look after them? So I would like to divide those into 2. One here in UK and other one in India. So in UK, the system is clear cut because the GP is there. And then by the time we are talking about like a chronic illness getting severe, deteriorating, specialists will get involved, and the specialists will refer to people to like a palliative care, and there's one called a specialist palliative care, that's a hospice, and the system is in place. It's like a 1, 2, 3, 4 system will happen here. But when we transcribe the same information to India, it's a bit tricky because the hospital is that the best place, and let's say hospital is for acute problems and then reversible problems, so it may not be accurate or appropriate for people who are deteriorating and in their last weeks or days of life, unfortunately. So the next option is home. Are there any hospices in India? There are all over India, and particularly Tamil Nadu. Yes, it is there. But is it like a specialist unit, or again, we need to inquire and then get the services, get to know what we need, what they want, and we need to match the needs and the offers provided by the hospice or like a specialist units in all over India. Home, that's where most of the people choose to be there rather than going to some other place in the last few weeks of their life. So when it comes to home, there comes what to do, which one to choose, and what to do. Do they need the nursing assistant? Do they need the registered nurse or generalist doctor or specialist doctor? That's always a puzzle. And this is one of the commonest calls I get from, okay, deteriorating, we want to keep him or her at home. So how do we do? Whom do I need? So that is where the thing is. First of all, I put nursing assistant. Nursing assistants are, so deterioration happen, frail and weak, but they need cares, everyday cares. Let's say feeding, and then like going on to the toilet needs and things they need. So they don't need any medical care, or they don't need any injections or anything. None of the problems are there. So those particular people will need only nursing assistant is enough. They don't need sophisticated other levels of healthcare at all. So with the nursing assistant, we can do them like a care and then keep them at home. The next level is the registered nurse. Because whenever, let's say, somebody is having a diabetes and then you need to give insulin and then the medications are there, and we as a carers, like friends and families, don't know what in terms of duration and all, and the registered nurse will look after. So there are some problems there. They are not stable, but there are still some problems going on top of deterioration. Then we need a registered nurse. And if let's say the blood sugar is going up and down and we need to regulation, what to do, then we need a generalist doctor. The specialist doctor come into play only in extreme situations where, like the specialist palliative care, that is where we need a specialist doctor. So what I'm trying to say is, when people deteriorate due to the general illness, chronic illness and deteriorating phase, when they decide to be at home, we don't need a specialist involvement all the time. It entirely depends upon what the problems they have got and how we need to control those problems. So I'm sure there'll be more questions on this because I get more frequent calls on those things. I'm happy to answer. So I will stop here. And the last take-home message, I would say, cure sometimes, treat often, comfort always. That's, I would say, the mantra for palliative care. And when I say cure sometimes, it may be in the Hippocrates era, cure sometimes, but now cure is lots of new medications, lots of new therapies. Cure is possible. But again, treatment often, again, I would say like a more often, but always comfort, keeping people comfortable is the key. The reason I'm telling this is, let's say one of our family or friends want to be at home, like for whatever reason, the preference is there. They don't want to go to hospital. We need to respect them and then make them comfortable. That is the thing, I would say, the key message for palliative care as well as a specialist palliative care. Thank you. Then is that question time. I'll come out of the share slide.
Thank you very much, Ramesh. It was, loads of information. These are some things which, I'm seeing, quite a few of my friends actually contemplating about this palliative care. This is something which is actually, as I had actually, kind of communicated in many of my WhatsApp messages, it's like kind of a least discussed, but like, most thought, but, people are like so difficult to actually discuss this kind of things, even with, another friend or, family. It's such a delicate subject. I will leave it open for, I can see Rajesh raising hand. Rajesh, you can unmute yourself and...
So Ramesh, what kind of support we do have for the carers? Sometimes it's not just a patient, isn't it? People who have lived with them for many, many years, they go through a lot of distress. Do you have any kind of carer support facilities? in your setup? In
Yeah,
palliative care, what can? Yeah.
Yeah. Because see, and that's why I didn't go in depth about the care. See, we do in a hospice setup, what we call like a specialist palliative care unit. We are not only doctors, we are called we have doctors, and then there's a group of counselors, what we call a family support team. It's every specialist palliative care hospice we have, and the family support team will be supporting them throughout the journey.
Okay. So the families will be kept informed at every stage. Yeah.
Yep.
And so even in the last stages, or when the patient is about, I mean, when the life is about to end, you inform them in advance, for the family. Okay, they all come over.
So from the beginning, let's say from the day of diagnosis, see, we hospice wise, the specialist palliative care is here for not only for patients and families. So from the day one, patients are also important and family is also important. We need to explain everything and then support them with the coping strategies.
What I'm saying is, are you talking about only a hospice setup? Because not all patients are the hospice, isn't it? See, they come to the hospice only in the later stages. So what happens in the initial stages?
Yeah, there are lots of, again, you are a psychiatrist, there are lots of mental health units, or there are lots of psychotic supports, or that mind support, and there are lots of activities.
See, I know that there are Macmillan nurses in hospitals, but in the community, is there anything ongoing? Is what I wanted to know sometimes.
Yeah, there are lots of services. Lots of services only dedicated to this. Lots of volunteers will support that. There's plenty of options there in the community.
Okay. Thank you.
Anyone else has any questions? Yeah, Suresh.
Ramesh, wonderful presentation. One thing like coping strategies, you said that about the coping strategies for the patient and the family members. What are the coping strategies as a palliative team they will provide for them to to accept the disease, whatever the disease, whatever the stage of the illness, what they are going to face, what are the strategies you try to implement. Thank you.
See, coping strategy, again, it's just like an ocean. So it's very difficult to say in 1 or 2 minutes. So in a nutshell, I would say the coping strategy is highly variable and it's different for individuals. But let's say I cope with certain things in a different way and you can cope different way. So the first thing is identify the coping mechanism and then support them in a whatever way they want. So it's very difficult to say there are like hundreds and hundreds of coping mechanisms for everyone. See, let's not talk about like a chronic illness and the palliative care. No, let's say even little things. Let's say we get overload work. You just go Monday, and then instead of seeing, let's say, I'm talking about like a doctor's life. Let's say seeing 5 patients, you've been booked 10 patients, and then suddenly things will come. How to cope? But that's a starting point. I would say this is just an example. I'm saying it's over your head, and then how do you cope? That's highly individualized. Some people know exactly what their coping strategies are, and then they will apply each and everything. But when people don't know their coping strategies and they are completely shocked, they can't even think about all those things in the deteriorating condition, then let's say the family support or the counselors and even the healthcare professional, the nursing team will support them to know about the coping strategies and then help them through various ways. So coping strategy is a wide and it's different for different individuals. And we are here to help them. If we know them, we help them. If we don't know, then we'll help them to find the coping strategy and then help them and support them through the journey.
Anyone else? Any other questions? Suresh, your hand is raised again. You can unmute and ask.
Yeah, that's what there are different coping mechanisms you said. Can you hear me? Yeah.
So, yeah, we can hear you.
Yeah. So what are those coping mechanisms? You said that they will support the patients and the families. In what way they can support? Like I know the being with the patients, telling them about the disease, the stage of the illness. This is going to be like that. So explaining about the disease is going to help in such a way. Like what are the other supportive mechanisms? I mean, supportive things you can do. Like, of course, being with the patient is more relieving the symptoms. That's one thing. But emotional support, what kind of emotional support? Sometimes I heard about the spiritual support and other things. So can you give some examples of what kind of supports things you can do? Like, I know the terminal illness, there are a lot of things to address apart from the medical related. Non-medically, what are things you will tell them? Or
See, I would say it's a completely difficult to cover in last 1 or 2 minutes. That itself is a separate topic. I would say we'll discuss another time, or offline. We'll discuss everything as a coping strategy. I think it's very difficult to say within 1 minute. It's complete. And one thing you said about spiritual support. So spiritual support is the starting point is being there. That's a spiritual support, and that's what we do all the times in the family and friends. See, whenever we don't talk about the chronic illness or anything, whenever let's say things are not going in the right way, we are a little bit down. The next moment is either you call your family or call your friends, and then just what we say in like a what to say, like a counseling. It's not a counseling. It's like a morning, and let's say in a classical morning, and then somebody to listen. The strongest coping strategy as well as the support is the listening. Actually, listening means clear listening. It's not about okay, you tell me and then I'll listen and then you ask so many questions. It's not like that. So where I don't know which angle you are asking. Are you asking? I'm not sure whether you're asking like a doctor or you're asking like a family member. The best coping strategy in any difficult situation or challenging situation is listening. Listening is the best support for everyone. Don't ask questions, don't probe, don't try to solve the problem. Just listen, being there. And that covers psychological support as well as spiritual support. Sometimes we see we don't talk or anything, just people will be sitting there next to them, makes a big difference for them. And then again with the friends, all of us, let's say, oh, if I have any problems, if I'm feeling low for any silly reason, can be silly, but feeling low is feeling low. But who can I tell? Who can I share? And it's not like when I say, for example, I call Suresh and tell, okay, I'm feeling low. Then Suresh started to analyze things. Okay, why you are low? It's a mathematics. Okay, 1, 2. That is not the support. The support is just listen. Just listen, offload, and then say people themselves know how to come out of the coping strategy. They apply. They're here for a long time. Let's say, for example, 30 years, 40 years. I know this is not the first situation. When similar situation comes, how would I have gone through? Then we need support to help. So in short, I would say listening is the key without asking any questions, without trying to solve the problem within 1 minute or anything. Listening is the key. There are plenty of coping strategies, and I would take it offline. Or if people do want, I'm happy to make another session completely different. Thank you.
thank you, Ramesh. I think what he is more worried about is he'll be like leaving other family members, in this world, alone. So if some arrangements can be done, or some kind of support system could be given to them, all their family members who are dependent on this particular person, definitely he will accept the illness and the end of life, and thereby whatever kind of coping mechanism he can adapt, I think it will be easy for him to follow. I think that's what I wanted to tell you. Maybe you can build up more on this strategy also. He is more worried about leaving behind other family members. That's more important, I believe. Is it correct? Yeah.
100% right. But as I said, it's very difficult to say in one sentence. You have used lots of like acceptance and then easy. Nothing is easy. It is difficult, and go with them with the journey. So I wouldn't use any word easy. I've never used it's like easy journey in my professional thought for 17 years. And people are different. Individually is different. So that's why I said like it's like an ocean. We need to assess first and then help with the coping strategy. And we discuss all these things. See, again, we asked about, unfortunately, when patient leaves the world and then how we support. That's called bereavement service. Bereavement service is an excellent service all over the UK, actually, wherever it is, whoever is doing it. So that service is the key for what the question you asked. Thank you.
Thank you.
Rajesh raised the hand again, and we are literally running out of time, tiny bit. So Rajesh.
Rajesh, you can unmute yourself, Rajesh.
Hello?
Yeah, Rajesh, we can hear you.
Oh. I just wanted to thank you, Ramesh. It was just an eye opener. So many times we come across patients with malignancy in hospital, and it is something, like even as a psychiatrist, for me, the end is something which is unacceptable. I don't want to face it, whether it's any of my friends or family, or even patients. It's one of the very, very difficult areas to even discuss. To be honest, even as professionals, we are also in a denial that anybody could be in that situation. So literally, you dragged us into facing the tough reality, and it was an eye opener. So I wanted to personally thank you. So that's why I texted the message, as well. Yeah.
Thank you.
Thank you, Rajesh. It's exactly, we are 2 minutes past 9 o'clock. I apologize that we had to start a little late, but I think Ramesh, it was indeed a fantastic presentation. And everyone else, if you have any questions, send an email to efof.shakes@gmail.com. Ramesh, you can bring the slide if you can, the last slide. So any questions, anything you can actually, I will just put it on this chat. Yeah, so that's the email ID, efof.shakes@gmail.com. So any questions, feel free to put it in there. Thanks everyone. We will have this session edited and loaded into the social media. Thanks everyone. Thank you, Ramesh.
Right, thank you. Thanks everyone. Bye-bye.